Now let's talk specific EKG changes from specific medications. I have patients on a number of medications, and we need to be aware that um, some of these medications might affect the EKG itself, either directly or maybe through an electrolyte change. So let's say we've got a patient taking Lasix and they're not keeping up with their potassium supplement, or just weren't prescribed a potassium supplement. Well, now we've got a potassium issue on top of that. So either indirectly or directly affecting the EKG. On the direct side of things, there are a lot of medications that affect functions of the cells, specifically those ion channels. Right, so potassium, calcium, sodium, chloride. Those channels are affected by these medications, directly affected by these medications, and because we want them to. If we think of antiarrhythmic drugs, our class 1 antiarrhythmic drugs, we want them to affect the sodium channels, right? So this is going to change how our cells are depolarizing, how they're repolarizing, and if we change that, then we're changing the vectors and playing with the vectors, and that's all going to culminate in sometimes a weird looking EKG, sometimes kind of just a abnormal looking EKG. So we're going to see some funky stuff on our EKG. I mentioned those antiarrhythmics. We know that these drugs are going to do something to our EKG, do something to our heart, because that's what they're designed to do. So our class 1 antiarrhythmics, right? AV blocks and slowed SA node, blocked SA nodes, lengthened QTCs, those QT intervals are lengthened, right? Calcium channel blockers, beta blockers, slowing everything down. Amiodarone, acting on the SA node, the AV node, the ventricles, TCAs, tricyclic antidepressants, widening everything out, right? So patients are on these medications normally, you know, prescribe these medications, and they're taking it as prescribed once a day, twice a day, whatever the dosage is, we might be seeing some EKG changes just because they're on, let's say, a beta blocker. One drug in particular that's going to affect your EKG, your patient's EKG, is going to be digoxin. And digoxin is going to create this very unique scooping of the ST segment, hallmark sign of this digoxin effect on the EKG, very specific sign of that. In this case, if we have a patient on digoxin and we see signs of hypokalemia, so hypokalemia exacerbates dig levels. So at that point, if your patient is hypokalemic on one hand and is on digoxin, in the other hand, that digoxin level is probably going to be toxic in any case. So we need to fix the hypokalemia before we do anything with the dig. But our digoxin, this kind of scooping, so this dig dip, it kind of looks like a ladle in your ST segment. Kind of this just been scooped out is what it looks like on the EKG. This scooping, this dig dip, can be seen just about anywhere on the EKG. So we see it really well here, V5, V6. Look at that scoop. It's just been scooped right out. A little bit in lead 1, but definitely in lead 2. So we've got this dig dip. We've got this scooping. What that tells us is that this patient is on digoxin. Doesn't say anything about toxicity. So if you see this dig dip, you see this scooping, that does not mean that the patient is toxic, has too much, their dig levels are just too high. Right? This just tells us that they are on dig, they're taking dig, and this is just a normal effect, EKG effect of that medication. If your patient is prescribed a tricyclic antidepressant, or TCA, we're going to be kind of on guard a little bit. TCAs have a very narrow therapeutic index. It's very easy to go into the overdose range, even if you took it in the morning and you didn't remember that you took it in the morning. So at lunchtime you took another one, you can go toxic just by doing that. So these TCAs, how they work, they block sodium channels primarily, and they also block potassium channels. So if we block sodium channels and we're blocking potassium channels, we are changing some vector. We're changing the way that the cells are depolarizing, repolarizing. And as your patient goes toxic with TCAs, we're going to see a prolonged QT interval. It's going to pull apart that QRS complex. They're going to go into heart blocks, eventually a third degree heart block, and then eventually some sort of ventricular rhythm. High risk for torsades, high risk for even monomorphic VTAC and VFib. So we're going to see, as maybe a patient took a little too many TCAs. We're going to see a widening of the QRS complex, prolonging of that QT interval, maybe a heart block, third degree heart block, and then eventually going into a ventricular rhythm. Here we have a TCA overdose patient, and we're kind of seeing that pulling apart of the QRS complex, just getting wider and wider and nastier and nastier. And as you stay with this patient without proper treatment, if you just let this cycle continue, we'll see the progression on the EKG of this widening, both of the QT interval and the QRS complex.